An analytical critique of Colombia's healthcare system, challenges, reforms, and pathways forward. Colombia's healthcare system stands at a precarious crossroads in 2025, embodying both the promise of universal access and the peril of systemic collapse. Once hailed as a Latin American success story for achieving near-universal coverage through the 1993 Ley 100 reform, the Sistema General de Seguridad Social en Salud, Sgsss, now grapples with a deepening crisis. Emergency rooms and maternity wards have shuttered across the country, leaving millions in limbo as providers cite insurmountable debts exceeding $8.2 billion USD. This turmoil is exacerbated by stalled legislative reforms under President Gustavo Petro, ideological polarization, and entrenched private interests that prioritize profit over public welfare. As of October 2025, with the Senate poised to debate health reform following a contentious September session, the system's fragility is undeniable. This essay offers an extensive analytical critique of Colombia's healthcare system, examining its historical foundations, structural components, notable achievements, and profound shortcomings. Drawing on recent data from government reports, international organizations, and independent analyses, it highlights how financial unsustainability, inequitable access, and regulatory failures have eroded public trust. Finally, it proposes targeted recommendations to foster resilience, equity, and sustainability. At its core, the thesis is clear. While the Sgsss has democratized healthcare access, its market-driven model has fostered inefficiencies and exploitation, necessitating bold, evidence-based reforms to safeguard the right to health enshrined in Colombia's 1991 Constitution. Historical evolution, from fragmentation to universal ambition. Colombia's healthcare journey reflects broader socio-economic transformations, evolving from a fragmented, elitist model to one of mandatory social insurance. Prior to the 1990s, healthcare was bifurcated. Urban elites accessed private care, while rural and low-income populations relied on underfunded public hospitals, resulting in stark disparities. The 1993 Ley 100 marked a watershed, inspired by Chile's privatized model, but adapted to Colombia's context of armed conflict and inequality. It established the Sgsss, mandating universal coverage through a tripartite regime, contributory for formal workers, subsidized for the indigent, and special for vulnerable groups like indigenous communities. This reform introduced entidades promotoras de salud, EPS, private insurers, as intermediaries between the state and providers, funded by payroll contributions, 12.5% of salary, and government subsidies. The Plan Obligatorio de Salud, POS, defined a basic benefits package, aiming to standardize care while introducing competition to drive efficiency. Early gains were evident. Coverage surged from 20-30% in the 1980s to over 90% by 2010, reducing out-of-pocket expenditures and improving infant mortality rates from 26 to 12 per 1,000 live births between 1990 and 2020. However, the model's neoliberal underpinnings sowed seeds of discord. EPSs, incentivized by capitation payments, fixed per enrollee, often delayed reimbursements to providers, fostering a cycle of debt. By the 2010s, scandals involving corruption, such as EPS mismanagement of funds, eroded confidence, culminating in nationwide protests in 2019 to 2021. The COVID-19 pandemic exposed these fissures. Colombia's hospital bed expansion from 2010 to 2022 was commendable, adding over 10,000 beds, but uneven distribution left rural areas vulnerable, with excess mortality rates 20% higher than urban counterparts. As of 2025, this history underscores a paradox. A system designed for equity has been undermined by privatization's profit motives. Current structure, a hybrid model under strain. The Sgsss operates as a managed competition framework, blending public oversight with private delivery. The Ministry of Health and Social Protection, MinSalud, regulates, while the administrative sector of health address pools and distributes funds. Coverage is near universal at 99%, with 50 million enrollees split roughly evenly between contributory, formal sector, and subsidized regimes. Funding totals approximately 7.5% of GDP, sourced from contributions, taxes, and lotteries, disbursed via the Unidad de Pago por Capitación, UPC, a per capita premium adjusted annually, 5.36% increase for 2025, aligning with inflation. Providers include public institutions, IPS Publicas, 140% of services, private clinics, and territorial entities. Primary care is emphasized through Equipos Básicos de Atención Integral en Salud, EPSs, but secondary and tertiary care dominate expenditures, 70%. Digital tools like the Historia Clínica Electrónica Única have advanced telemedicine, particularly post-COVID, yet implementation lags in remote areas. This structure's hybridity enables innovation. Colombia ranks 22nd globally in WHO's Healthcare Efficiency Index, but also breeds complexity. EPSs act as gatekeepers, approving treatments within the POS, which excludes high-cost therapies unless via tutela, constitutional lawsuits. In 2024, over 300,000 tutelas flooded courts, costing the system $1.5 billion annually in ad hoc approvals. Amid 2025's fiscal crunch, intermediaries hold only 20% of required reserves, signaling insolvency. Achievements, milestones in access and outcomes. Despite headwinds, Colombia's system boasts tangible successes that affirm the 1993 reform's vision. Universal coverage has halved catastrophic health expenditures, from 3.5% of households in 2000 to 1.2% in 2023, shielding vulnerable populations. Life expectancy rose to 77.5 years by 2024, outpacing regional averages, driven by vaccination campaigns, e.g. a 95% HPV coverage, and maternal health gains. Cesarean rates stabilized at 25%. The system's responsiveness shines in crisis. During COVID-19, Colombia sequenced the virus genome early and scaled ICU capacity 300%, averting worse outcomes than neighbors like Brazil. International partnerships, such as WHO's Country Cooperation Strategy, bolstered mental health integration, addressing conflict-related trauma in 20% of the population. Economically, healthcare contributes 5% to GDP growth via employment, 1.2 million jobs, and expat-friendly policies, allowing retirees EPS access, enhanced tourism revenues. These metrics position Colombia as a middle-income exemplar, with the Pan-American Health Organization, WHO, praising its benefits package evolution over 3 decades. Yet, as Bloomberg noted in August 2025, these gains mask a spiraling crisis, where coverage exists on paper but not in practice. Critiques: financial fragility, inequity, and privatization pitfalls. Colombia's healthcare system, for all its ambition, is a house of cards in 2025, critiqued for financial opacity, entrenched inequities, and a privatization model that commodifies health. Foremost is the debt avalanche. The Comptroller General's July 2025 alert revealed $8.2 billion in arrears, with EPSs withholding payments to providers for up to 4 months. This has triggered cascading closures, over 50 ERs shuttered by August, exacerbating wait times, averaging 6 months for specialists, and pushing patients into informal care. Financial unsustainability stems from UPC underfunding. Despite the 2025 hike, premiums lag true costs by 15 to 20% per Health Economics Review analyses. EPSs, numbering 26 but consolidating amid insolvency, e.g. the Sanitas's near collapse, siphon administrative fees, 10 to 15% of funds, while denying non-POS treatments, violating the constitutional right to health. Private interests amplify this. As People's Dispatch reported in April 2025, conglomerates like Nueva EPS lobby against reforms, restricting drug access and inflating costs via vertical integration, insurers owning providers. Inequity compounds the malaise. Rural and conflict zones, home to 30% of Colombians, face 40% lower bed density and higher mental health burdens, with catastrophic expenditures in these areas tripling urban rates. Indigenous and Afro-Colombian communities endure cultural mismatches, with only 60% POS compliance for traditional medicine. Gender disparities persist. Women in subsidized regimes wait 25% longer for reproductive services, fueling protests. Regulatory failures invite corruption. The 2024 Odebrecht-like scandals in procurement diverted $500 million, while INVIMA's delayed approvals hinder medical device imports. Politically, Petro's reforms, framed as deprivatization, face sabotage, stalling in Congress amid opposition claims of statism. BMJ's April 2025 expose detailed patient denials, with providers halting services over unpaid bills, eroding trust, only 35% approval per 2025 polls. In sum, the system is well thought out but poorly implemented, per LLYC Global, prioritizing markets over missions. The 2025 reform landscape: ambition meets resistance. President Petro's 2023-2025 reform agenda seeks to dismantle EPS dominance, centralizing funds under ADRES and establishing 10 regional health networks. Key pillars include eliminating profit-driven intermediaries, expanding the POS to universal benefits, and bolstering primary care via 5,000 new EBAs teams. By mid-2025, partial wins emerged. INVIMA streamlined approvals, boosting medical device market growth 8%, and Brazil-Colombia PACs enhanced regulatory transparency. Yet progress is glacial. The Senate's 7th Committee debate, anticipated post-September 24, 2025, risks dilution from opposition amendments. Critics, including patient groups and industry lobbies, decry potential wait time surges under public monopoly. Speyside Group's August analysis dubs it a bumpy road, with polarization, echoing U.S. Obamacare debates, threatening veto. As Colombia'S noted in July, cross-accusations have paralyzed action, leaving the crisis to fester. Recommendations: forging a resilient, equitable future. To transcend critique, Colombia must recalibrate toward a public-centric hybrid, blending fiscal prudence with social imperatives. First, fortify funding mechanisms. Index UPC to actual costs via independent audits, targeting 9% GDP allocation by 2030. Introduce progressive taxation on high earners to subsidize rural care, reducing debt through blockchain-tracked disbursements. Second, dismantle perverse incentives. Phase out EPS profits over 5 years, transitioning to non-profit cooperatives while mandating 80% fund pass-through to providers. Expand Tutelus into a streamlined appeals board, curbing judicial overload. Third, prioritize equity and prevention. Allocate 40% of budgets to primary care, deploying mobile units in conflict zones and integrating indigenous protocols. Mental health funding should double, addressing 2025's 25% prevalence in affected areas via community-based models. Fourth, leverage technology and partnerships. Accelerate digital health infrastructure, aiming for 90% electronic records by 2027, and deepen WHO World Bank ties for $2 billion in green health investments, e.g., climate-resilient hospitals. Fifth, governance reforms. Empower MinSalud with anti-corruption units and citizen oversight boards, drawing from Brazil's SUS model. Pilot regional networks in high-need departments like Chocó, evaluating via RCTs before national rollout. These measures, if legislated swiftly, could restore viability, potentially elevating Colombia's ranking to top 15 globally. Conclusion: Colombia's healthcare system, born of egalitarian zeal, now teeters on financial ruin and inequity, a stark indictment of unchecked privatization. Achievements in coverage belie a crisis of delivery, where debts devour dreams and reforms languish in partisanship. Yet in this moment of reckoning, as Senate debates loom, lies opportunity. By heeding critiques and embracing hybrid public innovation, Colombia can reclaim health as a right, not a commodity. The path demands political will, but the stakes, human lives, compel action. In 2025, the choice is clear: reform or regress.